Hi everyone, welcome. This is ACE Internal Medicine in Training exam, and we're going to do our topic in cardiology. Again, in service training exam, it's very, very important. You want to score the highest you can, and this is the way to do it. Start listening to our lectures. We already gave a talk on what? What was the talk?
Sarcoidosis.
No, it's not sarcoidosis.
Cardiac.
Everybody know about sarcoidosis. Sarcoid-induced or you can say cardiac sarcoidosis. Okay. What else I say? Samurai sarcoidosis.
Yes.
Remember, cardiac sarcoidosis. Today we're going to talk another topic: tachycardia induced cardiomyopathy. Okay. Tachycardia induced cardiomyopathy is another topic. You don't usually get much attention in the clinical practice, but they're going to ask for the board exam. They're going to ask you about in the in-service training exam, my friend. Okay. Now, you got like 3% in the people without any structural heart disease, okay? You don't have to have structural heart disease. 10% patient with atrial fibrillation or atrial flutter, risk factors, male, gender, high BMI, or history of cardiomyopathy. And then look at the causes. You could have SVT, atrial fibrillation, atrial flutter, AVNRT, and AV tachycardia. On the ventricular side, PVC is the word, my friend. Okay, you can have like 10,000 PVs or more than 10% PVCs. You can have bundle branch, re-entry ventricular tachycardia, idiopathic tachycardia. Okay, now everything we need to know pathophysiology, what happens. Keyword, tachycardia greater than 100 beats per minute. You need to know that. Your heart rate, and somebody is writing the question, the heart rate is going to be greater than 100, okay? Everybody know that when the heart starts beating fast, right? What's going to pull the blood in the ventricle? So you can have like a decreased cardiac output, that increase the catecholamines, increase ANP, increase renin, increase aldosterone. The contractile dysfunction is going to happen. So what's going to happen? Ejection fraction is going to go down. Also, you can have abnormal calcium channel transport, decreased calcium availability of myocyte. We all know you need calcium for the contraction, right? So eventually, all of this kind of lead to what? Decreased ejection fraction. So you need to know that. So it's going to be ejection fraction, usually maybe like 25 to 30%. Okay, that's the pathophysiology. So remember the word, tachycardia greater than 100 beats per minute. Okay. Now, so what are the things, how do you diagnose this? Usually people come with the palpitations, and then, the rejection fraction, EKG, you do like multiple PVCs, that way with a clinical picture. The first thing you need to make sure, you need to rule out all the other causes like thyroid, alcohol, and all those causes, okay? Don't forget to rule that out. And then you can do like a 2 to 14-day EKG monitor. And if there's a heart failure, you should initiate heart failure treatment. Everybody know that. Give like diuretics, tachyarrhythmia. So if there is tachyarrhythmia, there's no PVC burden, less than 10%, you can optimize the heart failure medications, okay? But if there is like PVC burden, like greater than 10%, then you have to think about ablation versus antiarrhythmic. You can do like rate or rhythm control, okay? So again, more than 10,000 PVCs, that's a word, okay? And then the good part of this thing is this is reversible. Okay, don't forget it. It is reversible. If you do all this treatment and if you correct the heart rate, it will come back to normal. But you need to rule out mainly you have to make sure you rule out the thyroid causes and all of that, okay? So the question is going to be like a 51-year-old male patient come with the palpitations, and then they will say no history of any thyroid disease. They might say, to confuse you, sometimes they put the question about the patient had a history of pregnancy, okay? So when you think about history of pregnancy, people automatically think it's like what? Pregnancy induced heart failure and all that too, but don't think like that. So the question is going to be what? It's going to be like a 50-year-old male patient, because it's more common in male, and have like palpitation but no history of any heart disease. You check the EKG, lots and lots of PVC, ejection fraction 35, very low, and the stress test is going to be normal. And what's your diagnosis? This is a lot of times in the internal medicine board is an in-service training examination. they'll never ask you about diagnosis. Did you notice that? They always ask about the treatment or like and all that. This is like a straightforward question you're going to find. What's the diagnosis in this patient? What are you going to write? What is your diagnosis? Tachycardia induced cardiomyopathy. Remember, the heart rate greater than 100 beats per minute, PVC burden greater than like almost like 10,000. Okay, those are the keywords you have to remember and all that. Thank you so much for watching. We'll be back with another presentation soon. God bless.